Good morning, Dr. Irwayan Surudharma, Master of Science as our facilitator, and Dr. Ngakan Ketut Wiraswastike, Master of Biomedical Science, Specialist of Internal Medicine, Consultant of Medical Hematologic and Oncologic as our evaluator. We from SGDB9 would like to present our student project presentation with the title of Diabetes Mellitus Prognostic Aspect Consideration with Critical Appraisal. This is SGDB9 group members. And now we would like to start from the introduction section. Let me introduce myself. My name is Maisa Isaka Aryasa with the last three digit of my student number is 230. And today I would like to start from the background. Diabetes mellitus is a group of metabolic diseases generally characterized by hyperglycemia that happens due to abnormality in insulin secretion, insulin function, or both. In 2021, it is estimated that 537 million people have diabetes, with over 6.7 million people aged from 20 until 79 will die from diabetes-related causes. The treatment of both type 1 and type 2 diabetes mellitus aim at managing blood glucose level and minimizing complication. Despite advancement in treatment modalities, significant challenge persists. The challenge of diabetes management is further compounded by the rising prevalence of type 2 diabetes in children and adolescents, which present unique treatment challenge due to limited therapeutic option and reliance on adult-based guidelines. Therefore, there is a need for critical appraisal based on evidence-based medical practice to determine the best evidence available for prognostic aspect in patients with diabetes mellitus. That's all from me. Thank you.
My name is Noe Adiadis Desari with your last digit of student number 084. I'm going to explain about the definitions and risk factors of diabetes mellitus. So, diabetes mellitus is a chronic condition that disrupt the body's ability to convert food into energy efficiently, that marked by persistently elevated blood glucose levels caused by issues with insulin production, function, or both. Diabetes mellitus can occur due to interactions between several lifestyles, medical conditions, hereditary, social, and demographic risk factors such as age, gender, obesity, family history of diabetes, physical inactivity, high serum uric acid levels, sleep quality or quantity, smoking, depression, cardiovascular disease, dyslipidemia, hypertension, and ethnicity.
Hello, my name is Puta Adisti Cecilia Sujana. My three last digit of student number is 241. I will be explaining about the pathophysiology of diabetes mellitus. So, diabetes mellitus is a chronic metabolic disorder characterized by elevated blood glucose level or hyperglycemia. It is primarily caused by a combination of insulin resistance and beta cell dysfunction. So, insulin resistance is a condition where insulin sensitive tissue fail to respond effectively to insulin. Elevated free fatty acid and pro-inflammatory cytokines contribute to insulin resistance, leading to decreased glucose uptake in muscle cells and increased glucose production in the liver. Meanwhile, there is also beta cells dysfunction, where beta cells compensate for insulin resistance by increasing insulin production. However, over time, this compensation fails, leading to reduced insulin secretion and worsening hyperglycemia. Meanwhile, on the molecular level, there's some mechanism that involves in diabetes mellitus. The first one is chronic inflammations, releases pro-inflammatory cytokines that contributes to insulin resistance. There's also lipotoxicity and glucotoxicity, where elevated free fatty acids and glucose level induce endoplasmic reticulum stress, leading to beta cells dysfunction. And lastly, there's oxidative stress, where these activate pathways that contribute to vascular complications associated with diabetes. That is all from me. Thank you.
Okay, hello everyone. My name is Iputudiva Planaharta with three last digit names number 238. So I'll continue the presentation about the diagnosis of diabetes mellitus. So there is some of diagnostic criteria for the diabetes mellitus from ADA guidelines. The first one is fasting plasma glucose or FPG for more than 126 mg per dl or 7.0 millimole per liter. And then the second one is glycated hemoglobin or A1C levels. There's more than 6.5%. 2-hour plasma glucose, there's more than 200 mg per dl. during an oral glucose tolerance test or OGTT. The fourth one is random plasma glucose. There is more than 200 mg per dl in symptomatic individuals. And then the auto antibody testing for type 1 diabetes confirmation. Maybe that's all from me. Thank you.
My name is Karen Angela and my student ID number is 210251 11116. So the first prognostic indicator for type 2 diabetes mellitus is the glycemic status, where the primary tool to assess it is the glycated hemoglobin or HbA1c test. Second is insulin resistance through the homeostasis model assessment for insulin resistance or HOMA-IR test. And third is the lipid profile test, which consists of total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. Then the cardiovascular parameters such as blood pressure and kidney function tests like urinary albumin to creatinine ratio and estimated GFR, as well as the liver function tests, for instance, alkaline phosphatase, gamma glutamyl transpeptidase, and serum glutamic pyruvic transaminase. Last is the obesity and body composition assessment through the body mass index measurement, waist circumference, waist to hip ratio, and waist to height ratio.
My name is Gultim Ragung Radeangsa with my last digit number is 144. Now I will explain about the limitation of current prognosis indicator. Number one is glycemic status. HbA1c is a common marker for glycemic control that can be influenced by various factors like hemoglobin variations and anemia, leading to inaccurate readings. It may not be a reliable standalone measure of long-term glycemic control. Number two is insulin resistance. HOMA-AR is a tool to assess insulin resistance. It has a moderate predictive power to assess diabetes risk. Its accuracy can be affected by factors like age, gender, and metabolic syndrome components, limiting its reliability as a sole predictor. The next one is lipid profile parameters. Lipid levels can fluctuate due to various factors, making it challenging to rely solely on them for diagnosing prediabetes or diabetes. This can lead to misclassification of individual at risk. The next one is kidney function test. Traditional kidney function tests may not be accurately reflect kidney function in all patients, especially those with early-stage diabetic kidney disease. A panel of biomarkers is recommended for better classification and treatment. The last one is liver function test. Liver function tests like ALT or ALP have limited predictive power in differentiating between diabetes or normal glycemia. They also can be influenced by various factors, which is affecting their accuracy.
Greetings. Hi, my name is Sugiyati Putri with your last test number 235. Now we're going to move on to 2.6 evidence-based medical practice to determine prognosis indicator for diabetes mellitus. For the next chapter, we're going to talk about foreground question and clinical research question using PICO. It is based on scenario 9 regarding finding the research evidence about homocysteine levels as the markers that can predict the mortality rate patient, especially for diabetes mellitus patient. For the PICO's framework would be P, patient population problem for diabetes mellitus. I, intervention or exposure would be homocysteine serum levels. For C, comparison would be homocysteine serum levels or patient with no measurement. And the last one is outcome is for prediction of mortality. So the clinical research question would be in diabetes mellitus patients, does measuring serum homocysteine levels compared to not measuring them improve clinical decision making regarding their mortality risk? That's all from me. The next chapter will be talked with my friends. Thank you.
My name is Aisha Fatakia with 3 last digit number is 076. 2.6.2 Critical Appraisal. Point 1 Validity Aspect. 1. Recruitment. Participants were selected from the National Health and Nutrition Examination Survey, which used stratified multistage probability sampling technique to generate a nationally representative sample of the U.S. non-institutional civilian population. This resulted in a final cohort of 22 and 86 adults with diabetes from an initial pool of 25 and 69 diagnosed individuals. 2. Allocation. Participants had been no longer randomly adopted. Instead, they had been analyzed primarily based totally on their serum homocysteine levels. 3. Maintenance. Data on various categories were collected through standardized questionnaires during household interviews. Measurement. Measurement of serum homocysteine level. Serum homocysteine level were measured using the Abbott homocysteine test. Outcome assessment. Mortality outcomes were obtained through a linkage with the National Death Registry. Statistic analysis. The study used Cox proportional hazard regression models to analyze the association between serum homocysteine level and risk of death.
Hello, doctor and friends. My name is Christine Natalia with the Trilas student number 109, and I'm going to present the importance of critical appraisal. Critical appraisal is important in evidence-based medicine, especially for understanding prognostic indicators in diabetes, as it helps to assess research quality and focus on studies that are useful and well
Hello, my name
conducted,
is Sabrina Pridhamita
evaluate
with
study
TDG
design
student
and
ID number
results to ensure
190.
findings are accurate
Participation
and
of the
not
patient about
biased,
study result. The
prevents
study
wrong
result
conclusions
indicates that
about
serum
diabetes
homocysteine
treatments
level
and
are
outcomes,
significantly associated
identifies
with an increased
reliable
risk
predictors,
of
for
all-cause
example
and
biomarkers,
cardiovascular mortality
to
in patients
improve
with type
treatment
2
and care for
diabetes.
patients. And
Analysis
the
of
last one
data
is
from
using good evidence in practice to help
2.286
create
diabetic
better
patients related
strategies
that
and
higher
decisions for
homocysteine
individual
level
patients.
were
Thank you.
consistently linked to
Hello, my
greater
name is
mortality
Indiana
risk,
Mantasano with
including
last
a
digit name
2.334 increase in
2.6.2
all-causes
critical
mortality and
appraisal.
a 2.24
Applicability.
fold increase
Research
in
has underscored that
cardiovascular
EVM's
mortality
contribution to
compared
enhancing
to
diabetes
patients
care
in
and
the
patient
lowest
outcomes. Glycemic control
homocysteine
remains a key
quartile. Further,
prognostic indicator.
analysis showed that this
Lifestyle interventions have
association
consistently emerged as
was
critical in DM
particularly
management,
strong in
and the
patients with
pharmacological
autoimmune disease.
strategies
The
has
finding
also
from
evolved with
COX
EVM.
proportional hazard regression
And then
demonstrated a linear
cardiovascular risk is a
relationship between
priority
homocysteine level and
for
mortality
EVM
risk with
to be
significantly elevated risk observed
to
in
not
patients with
happen.
higher homocysteine
And
concentration.
strategies
Additionally,
such as
top-line
reducing
measures of
adiposity,
alcohol
increasing
control
physical
highlighted
activity, and
higher
managing
mortality
hypertension and
rates
preventing
among
smoking are
patients in the
critical
higher
in
homocysteine
minimizing major
quartile.
adverse
Moreover,
cardiovascular events.
incorporating
A
homocysteine
2024
as a
review
biomarker
underscored the
into the
significance of
10 years
applying
mortality
evidence-based
prediction
care
further
strategies in
improved risk
practical settings.
classification
It
capabilities,
showcased
and
successful
as evidenced
implementation
by
efforts
a
targeting three crucial
NEF
aspects of
classification
diabetes
index
care:
of
prevention of the cause, improvement of the
0.253 and an
glycemic
integrated
control, and
distribution
reduction of diabetes
improvement
related
of
complications. For me,
0.011.
the next
This
part will be
indicated
explained by my colleague. Thank you.
that homocysteine provided additional prognosis value for its stratification in diabetic patients compared to other inflammatory biomarkers such as C-reactive protein. Thank you.
Thank you so much for your time. So now I will tell you about the summary. My name is Deputo Adhika Prayana, 178 with the the last digit number. So diabetes mellitus is a metabolic disorder causing chronic hyperglycemia due to impaired insulin function. In 2021, it affected 537 million people globally, leading to 6.7 million deaths. Type 1 DM arises from autoimmune B cell destruction, while type 2 stems from insulin resistance influenced by genetics, lifestyle, and obesity. ADA diagnosis criteria including fasting glucose with more than 126 and A1C is more than 6.5%, or 2-hour glucose more than 200 milligram per deciliter. Tools like CGM and biomarkers such as C-peptide aid early detection and personalized care. Prognosis tools like A1C, kidney tests, and obesity matrix guide management through the miss early disease. Emerging biomarkers like serum honeymoon predict cardiovascular risk, supporting cellular treatment to reduce DM global burden.